you're going to do your infection control. Whole aided thing. Hi, sir, madam. I'm Lili. I'm going to be your RT. I'm going to be performing an NTS maneuver with you today. NTS stands for nasotracheal suctioning. Doctors order this because it looks like you're having a hard time clearing your secretions, even though we're doing non-invasive tactics with you, all this good stuff. So I'm going to help you clear that with this suction catheter here in a moment. So looking to verify your name, date of birth, medical record number, all that good stuff. Then I'm going to check my patient's vitals. So by assessing breath sound, 6 in the front, 6 in the back, heart rate, all that stuff is within normal limits. I feel like it's comfortable to do this. The only thing is my patient may have coarse crackles, indicative of the patient having those increase in secretions. I'll mention to the patient that I took a look at their chart before entering the room to, number 1, verify the order, and number 2, note if they are a good candidate for this procedure. They are a good candidate because I know they will not be susceptible to increased bleeding. And I saw that because platelets are within normal limits. They're not on any blood thinner. They're not indicative of any trauma that would be susceptible to more bleeding. So I feel like even though this is an invasive maneuver and there's that potential for bleeding, there's no concern for significant bleeding with you. So now that I have my vitals assessed and I know he's a safe candidate, I want to gather the equipment of my suction, or I'm sorry, my oxygen therapy, the non-rebreather. Get that plugged in aseptically. Get my bag inflated, but I'm going to turn it down in a second so you guys can hear me better. Minimum of 10. So I'm going to pre-oxygenate you, sir, madam, because this is an invasive maneuver, which means it's going to kind of suck the air out of you. So I'm going to preemptively strike and get you on some plenty of oxygen before we actually start. Part of starting is also getting my suction set up, and the suction pressure for an adult has to be -100 to -120 millimeters of mercury. On this particular machine, the blue one, the EasyVac, the units of measurement are centimeters of mercury, so I'm going to make sure I set it to 10 to 12 centimeters of mercury. The way to set suction is by turning it on the toggle here, and then occluding the suction port and watching where the needle lands, and using low-high to get it within 10 to 12. Now, if this was real life, of course, it would be on the whole time. And by the way, if this was real life in the hospital, the suction would be on the wall. It wouldn't be on a machine. This is home unit machines that you see in home health. So it would be on technically this whole time. I'm going to leave it off because it's a little loud. But now that I've pre-oxygenated, I got my suction pressure set up, the next thing I want to do is make sure my yonker and my basin and my lubricant and my water's nearby. Can I have the water, please? Thank you. I have water that I can put in the basin. I'll put 2. And I want the water in here to, number 1, check the suction pressure of the catheter itself, make sure there's no tears in it. And then number 2, to clear the tubing once I'm done with the maneuver. I'll have my yonker set up in nearby, like ready to be accessible and easily adapted to the suction port itself. Now that I feel like everything's set up, I feel like it's safe to go ahead and actually engage in sterile technique. This is the last thing you want to do because as soon as you have your sterile gloves on, the concern is if you forgot any of the steps and you have your sterile gloves on, there's the potential for now having to do everything with one hand, which would obviously mean you're at a greater risk for messing up your sterile technique. The gloves, they come in folded over, so it's okay to touch them with your non-sterile gloves from the inside. This part can be a little tricky, so this is why I wanted you guys to have kits to practice this part. Pulling from the folded over part. Always when I'm being filmed. There we go. Now this is a sterile glove, so I will feel confident in touching it from the outside from here, but this is a dirty glove, so I still have to maintain maneuver from the folded over part here. But since this is a sterile glove, I feel confident in doing this part like that. I'll go ahead and fish my dirty hand inside. And now I can use the sterile hand to easily get this one on. I like to just do that to make sure they're on there nice and good. And then in the competency, you're going to identify to me which one's your clean hand, so I know which one to watch like a hawk. Because that clean hand, the only thing I can touch is the catheter. This dirty hand, it can touch the connecting port, and it can touch everything else as needed. This overlay is here. So my dirty hand is going to put down some lubricant. Already got my water. I need to get this connected. If suction was on, I would next come over here to the water and dip, make sure that suction was adequate. I like to do the twist around my hand technique so I don't accidentally touch dirty things with the catheter. So hold it like this, nice and taut. Once you're ready to actually engage in the maneuver, you can remove your patient from the oxygen therapy. Let them know we're about to invasively suction you. So as I'm about to enter your nair, I need you to take a deep breath in. I'm going to feel some resistance at some point. I'm going to pull back, and then I'm going to suction at that point, and you're going to feel the sensation of the secretions being removed. Are you ready? I want that confirmation from the patient that they are still willing to give you technique, because this is the scary part where it's actually about to happen. Notice that I am not occluding the port on entry. The port, when it is occluded, is activating suction pressure, so you only activate suction pressure after you've removed that 1 to 2 centimeters from the carinal space. So no occlusion of the port. Are you ready? Introducing the catheter with my rotation technique. Going in a fair amount of space until I feel that resistance. Once I feel resistance, you'll see numbers on the catheter, so if you really want to be precise about it, you'll go from 40 to 38 or 2 centimeters, wherever it is. And now that I've pulled back 2 centimeters, now I can occlude the suction port and begin my maximum 15 seconds of suction time. And I like to do the rounding technique as I'm coming out so I can get all sides of the airway wall. Suction, 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 cough, cough, cough. Getting all that good stuff out. Now that I feel like I've got the majority of it, the very next thing I immediately have to do is get my patient on their oxygen therapy, because I just knocked the wind out of them. And this is where I get my yonker, connect it, and quickly suction out their mouth for any secretions they might have coughed up into their mouth. Now notice, as soon as the maneuver was done, I had to use both hands to get them on their oxygen and their yonker. So of course I don't have sterile technique. So now when you're trying to assess if the maneuver was helpful and you find that it was not, and you do have to do it again, you simply have to start over, because these hands are not sterile anymore. But you ask the patient, do you feel like it was successful? Do you feel like you cleared your secretions? They'll say, yes, I feel a lot better. You don't want to rely just on subjective information. Make sure you assess breath sounds and vitals and all that stuff afterward as well. And I will indicate to you that you've cleared secretions, that they sound clear if you did the maneuver successfully. And at that point, you can start to conclude the therapy by suctioning out the water basin again, making sure you're clearing your tubing, removing your patient from the oxygen therapy that was only used for nasotracheal suctioning, and make sure the patient knows that this is a as-needed frequency, so they'll see you again if there ever is a need for secretions again, and then you'll document all that good therapy and say thank you and all that good stuff to your patient.
Nice. Thank you, Ms. Berni.
Okay, now you guys do it. I've done it enough.